Great, thanks, Jeremy, and good afternoon to everyone. As Jeremy said, Staph aureus bacteremia is something that hasn't really been well researched in the past, but is a very common clinical entity that we really encounter in our daily practice. So today I wanted to cover a few things. Hopefully by the end of the talk, we'll make sure that we answer some of these questions. So why is it an important clinical entity? How should we really work it up? Do we really have to do an echo for all cases of Staph aureus bacteremia? Interns would often be asking us this question when they're running around trying to motivate for them. Should you consult infectious diseases if you have an infectious diseases physician available at your institution? Do they provide any value whatsoever? What about cloxacillin versus cefazolin? We often have issues with the availability of clox, but can we use cefazole interchangeably? What about MRSA? How does that change your therapy? Can we even give oral therapy for Staph aureus bacteremia? And then finally, we'll go over a little bit of a summary as to how to remember to manage Staph aureus bacteremia with a little mnemonic called lime and soda. So Staph aureus, where does the actual word come from? So Staphylococcus, the word is derived from the Greek term staphyle, which means a bunch of grapes. A coccus we know is a round or spherical bacterium, so a round bacterium that forms a bunch of grapes, basically. And aureus is basically derived from the Latin. Aurum means gold. And you could think of the Aurum Institute associated previously with gold mining, now doing a lot of TB research. So they are gram-positive cocci. They're catalase positive, coagulase negative. And I always like these figures from, I think it's from the Toronto Notes, which kind of enables you to see where bacteria fit amongst other kind of gram-positive bacteria. So if we look at gram-positive bacilli, you can see your Listeria, Clostridium, your branching filaments. We can divide up into those that are acid-fast nocardia and those that are not acid-fast, like Actinomyces, amongst others. And then your cocci, which are by far the majority of gram-positive bacteria. And that can be divided up into those that form chains, those that form clusters. So those that form clusters also catalase positive, so the staphylococci. The coagulase positive staphylococci, most important one is, of course, Staph aureus, and your coagulase negative staphylococci as well, which we're not really going to talk about today. We're going to focus on Staph aureus, which sits over here. Staph aureus on gram stain looks like this. You can imagine little bunches of grapes, so that makes sense. On culture, it may be quite kind of goldish at times, sometimes just cream, and so that's where the aureus aspect comes from. And you can then imagine, understanding this, why an author may term the review on Staph aureus the golden grapes of wrath. So that completely makes sense when you understand a few things about why Staphylococcus aureus is called what it is. So in terms of epidemiology, the primary reservoir is basically the human nose, but it's also present in the vagina, pharynx, axilla, and other skin surfaces. I think a case was presented on one of these meetings that we had here at Charlotte, which was actually a Staph aureus bacteremia associated with a incomplete miscarriage. So we do know that staph is all over the skin, including in the vagina. 30% of the population are colonized with Staph aureus. That's a rough estimate. More healthcare workers and patients are colonized than the general population. And risk factors for colonization amongst patients include diabetes, renal dysfunction, particularly those that are on dialysis, IV drug use, and even HIV. Transmission generally occurs via direct contact. So this is, we're not washing hands, transmitting between patients or from patient to patient, and also fomites. And because of this, you can have hospital outbreaks, which we know can be quite common, particularly in areas where patients have got immune compromise and are particularly vulnerable, so burns units, neonatal ICUs, and other ICUs as well. Why is Staph aureus such a virulent organism? Well, it's because it's got lots of different virulence factors. It's got enterotoxins. Staphylococcal enterotoxins can be labeled A to E. Staphylococcal enterotoxin B is one that we used when I was doing some immunological work as a kind of super antigen for stimulation of even T cells. So very potent toxin, toxic shock syndrome, toxin 1. There's cytolytic toxins, which include the hemolysins from alpha to delta, the leukocidins, which include the penton-valentine leukocidin or PVL. Exfoliative toxin associated with the scalded skin syndrome, and then other enzymes as well as proteinase. So there's many different proteins that are produced that can be toxins that assist Staphylococcus in being the virulent organism that it is. So the clinical syndromes that it causes in terms of clinical manifestations, skin and soft tissue are most probably some of the most common. They can be primary pyodermic or other deeper soft tissue infections that may be associated with cellulitis, pyomyositis. Cardiac can be infective endocarditis is at the top of the list, but obviously we know it can be a pyogenic pericarditis. Pulmonary can cause a pneumonia, can also affect the pleural space in terms of an empyema, or even lung parenchyma in terms of an abscess. Osteoarticular involvement, osteomyelitis, also septic arthritis and prosthetic joints. Neurological symptoms with a meningitis or even brain abscesses, and then bacteremia, which is what we're talking about today. Some of the clinical manifestations are associated with particular toxin-mediated conditions. I mentioned scalded skin syndrome, toxic shock syndrome, as well as food poisoning. And one of the aspects about the food poisoning associated with the staphylococcal enterotoxins, I think D, particularly associated in A, is that they're quite heat stable. So even heating up food doesn't may kill the organism, but doesn't eradicate the toxin, and so can cause quite a violent gastroenteritis. What is Staph? Well, what is Staph aureus bacteremia? Well, it's pretty self-explanatory. It's detection of Staph aureus in the bloodstream, and this is obviously done by blood culture. So at this point, I wanted to ask the audience one question, and that is really, how common is Staph aureus on blood culture a contaminant?
We'll give another 5 seconds. Okay, sharing the results.
Great. So we had a pretty good, about 60% of the audience participated. The most people said about 0.1%, but there's really a broad mix. So some people said 5%. That's about 30% of the audience. 8% said 80%. 16% said 30%. So the correct answer is 5%, between 5 and 10%. So this is very important because as opposed to Craigley's negative Staph, Staph aureus is not commonly known as a contaminant. So you really need to consider it seriously when you do pick it up on a blood culture. So between 5 and 10% generally. So as I said, blood culture contamination is rare. And so this was an interesting study that looked at the clinical significance of Staph aureus in a single positive blood culture bottle. So where they had patients that had multiple blood cultures done at the same time, and they followed up those that had a single positive and those that had multiple positive. And they showed that among the cases with a single positive blood culture bottle, about 90% were classified as clinically significant. So only 10.2% were considered contaminated. And most of these patients received treatment, but obviously those that had, what they did show that those that had multiple positive blood cultures generally were treated for longer, had a longer hospital stay, which may relate to the kind of the inoculum and the density of infection. But the point of it is that even a single positive blood culture bottle is relevant, and so you should always consider it to be real. And where it is a contaminant is normally where there's a patient with significant skin abnormalities, patients who've got exfoliative skin conditions, where there's easy kind of penetration or contamination of blood cultures. So why do we fuss about Staph aureus, particularly Staph aureus bacteremia? Well, it is second only to E. coli as one of the leading causes of community-acquired and hospital-acquired bloodstream infections. The incidence is pretty high, but most importantly, hospital mortality is really high. So it ranges between 15 and 40%. And of course, quite a high proportion of patients Staph aureus bacteremia may lead to other secondary complications. And this is all associated with morbidity and mortality. Another important point is that the management differs to that of other causes of bloodstream infections. So if we look at this mortality between 15 and 40%, that is really massive. If we think of someone admitted with a myocardial infarction, that mortality associated with an MI is around about 10%. So this is significantly higher. If we look at some local data, this was a study done at Virulence, where they had 100 patients with Staph aureus bacteremia. 30% were community acquired, the rest were hospital acquired, and at a close to 50% 90-day mortality. This is the initial study. And if you look at the factors that were associated with mortality, there was nothing statistically significant, but it was there's a trend towards an association with MRSA, and also to presence of comorbidities. Age also was getting close, but nothing was statistically significant, most probably because of the numbers. The study was then followed up with another study done a bit later, where they were looking at the effectiveness of an intervention, a Staph aureus bacteremia kind of care bundle. What I was just looking at here was the mortality, and was shown to be about 18%. This study was done a good few years later and significantly better, but still 1 out of 5 patients dying who are being managed for Staph aureus bacteremia, and that's pretty significant. So what is complicated versus uncomplicated Staph aureus bacteremia? So this is an important distinguishing factor or important determination to make. So uncomplicated Staph aureus bacteremia would be where there's no evidence of endocarditis, there's no implanted foreign bodies, blood cultures are negative from about 48 hours after initiation of therapy, and there's no evidence of metastatic infection. Also, these patients generally get better within 48 to 72 hours. And this is in contrast to complicated, which is basically anyone that doesn't fit these criteria. So blood cultures persistently positive. This was a previous study that looked at odds ratios associated with mortality, community onset fever for a longer period of time, skin findings are concurrent with systemic infection, and then persistent or basically undrained focus of infection. Also, obviously, endocarditis, prosthetic valve or intracardiac device. Other ones that are less they're supported by evidence, but in some studies shown to be associated with complicated infection. Some more commonly would be elderly age and MRSA as well. So it's important to know exactly what risk factors are associated with a poor prognosis. And apart from the factors associated with more complicated infection, is an association between duration of bacteremia and mortality. So the longer someone is bacteremic for, the higher the mortality is. And that has associations with some of the factors associated with that we spoke about now as part of complicated Staph aureus bacteremia. So in this study, they showed that metastatic complications, 30-day mortality, were generally, and length of stay got worse as bacteremia duration increased. And basically every continued day of bacteremia was associated with a relative risk of death with a hazard ratio of 1.16. So basically a 16% increase in risk of death for every day that a patient was still bacteremic. The factors that were associated with this was the MRSA and delayed source control. And factors that weren't associated with it, interestingly, were the MRC of the isolate, the choice of antimicrobial, or actually where it was MRSA switching from vanco to daptomycin. It's also important to consider when you have a patient with Staph aureus bacteremia, what the source is. So this was basically a meta-analysis looking at a bunch of different studies and looking at those with Staph aureus bacteremia and where the primary focus of infection was. So some patients in different studies obviously had no known or an unknown source of infection. I mean, the values range from kind of about 10% to about 70%. But quite importantly, line-related and skin and soft tissue were the most common. And infective endocarditis in patients with Staph aureus bacteremia ranged from kind of 3% up to about the highest was about 14%. So this raises the question, when you're searching for a source in Staph aureus bacteremia, what about the need for echo, considering not just how frequent infective endocarditis is, but also how frequent asymptomatic endocarditis is as well. So what about a need for an echo in Staph aureus bacteremia? So this study looked at mortality in patients with Staph aureus bacteremia, and showed that patients who had an echo of any form, which was not specified, or either TE or TT or transthoracic echo, had reduced odds of death as compared to those that did not have an echo. Also, echocardiography is supported by the ESC and the RDSA guidelines. And considering that greater than 18% of patients with Staph aureus bacteremia associated endocarditis did not have any clinical stigmata. So generally, there is a need for echo Staph aureus bacteremia that is supported by improved or reduced mortality. And so we should consider transthoracic echo for all patients. And we can use a transesophageal echo in high-risk patients, particularly those with embolic events, intracardiac devices, IV drug uses, and previous infective endocarditis. But is there really an exception? Are there some patients that you may not need to do an echo for? And I think we're starting to realize that as well. For some patients, specifically selected patients, it may not be necessary. And so there may be exceptions for those that are healthcare associated, and combined with an absence of an intracardiac device, combined with an absence of features of endocarditis, as well as a negative blood culture at 48 to 72 hours. So maybe in that group where you've got a pretty specific source, where you don't have other complicated factors, it may not be necessary to do an echo, but guidelines currently do suggest it, although those may change, and some expert opinion does suggest that you may not need it in these cases. There are a bunch of clinical scoring systems that do give you the risk of having endocarditis in patients with Staph aureus bacteremia. And similar to, there are some scoring systems for enterococcal bacteremias that will give you an idea as to whether you should be doing an echo. So there's the PREDICT score, the positive score, and the VERSTA score. And if you're interested in that, go have a look at them. But where you do have easy access to an echo, it's generally is suggested as an important, a very important aspect of managing a patient with Staph aureus bacteremia. What about an RD consult, where you have an RD physician available? Is it evidence-based? I mean, does consulting an RD physician actually result in improved mortality? And there have been quite a few studies that look at the references to the bottom right that have shown that there are improved outcomes with Staph aureus bacteremia associated with inpatient RD consultation. And that also that consultation, there's improved mortality when someone actually comes to the bedside and sees the patient, rather than giving some advice over the phone, although giving advice over the phone may be better than nothing. And then if you had to choose between getting an RD consult and getting an echo, or just giving the right therapy, generally, this is a study by Gotu et al., which showed that RD consultation alone was looked superior to either echo or appropriate therapy alone. So it is important, if you have access to an RD physician, to get a consult. I know that at Helen Joseph and here at Charlotte, we have a close relationship with the micros, and we try and see every single patient who has a Staph aureus bacteremia with the infectious diseases services. So let's move on to management. An important part of management is really just having a cycle or a process of care. So this is adapted from Lamb and Stokes, which showed just a basic schema of how to manage a patient with Staph aureus bacteremia starting with empiric antibiotics. That empiric antibiotic choice we'll go over now. It does depend on your local antibiogram, particularly with relation to Staph aureus and the presence of MRSA. Doing a thorough history and physical examination, and in this case, you're looking for a source. You're making sure that there's no features of endocarditis and looking for metastatic complications. Looking for any prosthetic material, look for any previous risk factors that may be associated with different procedures, and then looking also for particular symptoms that may be associated with vertebral osteomyelitis, so new or worsened back pain. Then other things that would be important would be to repeat the blood culture within 48 hours and until you document clearance, getting an echo, doing the appropriate imaging, obtaining the appropriate source control and consulting ID. And thereafter, you can optimize antibiotics based on what susceptibilities show in terms of whether you're dealing with an MSSA or MRSA. So for methicillin susceptible Staph aureus, one of the big questions is whether we can use cefazolin in the place of an antistaphylococcal penicillin, such as cloxacillin, which is the one available to us. Sometimes you may have access to flucloxacillin overseas, or you may have oxacillin, but our antistaphylococcal penicillin is cloxacillin. So this was a meta-analysis and systematic review looking at many studies that have looked at the difference or the outcomes of an antistaphylococcal penicillin versus cefazolin. And looking at 90-day all-cause mortality, there was no difference. If anything, slightly favored cefazolin or cefazolin, depending on how you say it. Treatment failure and relapse, no significant difference. But in nephrotoxicity, there was actually a significant difference in benefit towards cefazolin. So although this is looking at mostly retrospective data, there are some new ongoing clinical trials that should answer this question more in a kind of prospective, a randomized controlled trial way, and most notably the SNAP trial. But so far, it doesn't seem like there's much difference in using a cefazolin versus antistaphylococcal penicillin. And actually the American guidelines, at least for endocarditis, suggest cefazolin as a secondary agent. There is one issue associated with using cefazolin, and that is this inoculum effect. So this is described as an increase in the MRC at a high inoculum, so an inoculum that's 10 to the 7 or higher versus a standard inoculum. And there was one particular study in Argentina that showed that some patients who had this inoculum effect had poorer outcomes. This hasn't been supported in 2 other studies, but there is a slight worry about it. So 2 other studies have not shown the same effect, and the original study was quite small and not well powered. So whether or not this is an issue is not 100% clear, although we seem to be drifting away from its importance. What about using vancomycin instead of a antistaphylococcal penicillin? So we generally have this idea that vancomycin is a super potent drug. But what we do know is that it is actually inferior for the treatment of methicillin susceptible Staph aureus. It's a different story, obviously, for MRSA, where obviously your antistaphylococcal penicillins will not work. So this was a study that looked at a comparison and looked at beta-lactam versus vancomycin, or antistaphylococcal penicillin or cefazolin versus vancomycin, and showed reduced hazard ratios for the beta-lactam or with the antistaphylococcal penicillin or cefazolin versus vancomycin. So vancomycin is not generally used for definitive therapy for MSSA. This study also showed that when you're using it for empiric therapy initially and then switching, there wasn't any difference in mortality once you were switching to the appropriate directed drug. How long should you treat for? So generally, uncomplicated Staph aureus bacteremia treat for about 14 days. we generally say at least 14 days. So less than 14 days versus 14 days. The study was done which showed a relapse in 8% that were treated for less than 14 days versus 0% for those that were treated for 14 days exactly. But then what about for treating them more than 14 days? So this study looked at treatment failure and showed that treating for more than 14 days was not really associated with a higher incidence of treatment failure. It was statistically significant. And actually, catheter-associated adverse events were higher in the group that were treated for longer. Otherwise, there was no statistically significant differences between the groups, considering that this was also quite a small study. So generally, 14 days is what we would suggest for uncomplicated Staph aureus bacteremia. If it's complicated, we treat for at least 28 days or longer. And this really depends on the site of infection and response to treatment. Remember, uncomplicated, we're saying there's no evidence of endocarditis, no implanted foreign bodies, blood cultures are negative within generally 2 to 3 days, and no evidence of a deep-seated or metastatic infection. Also, patient generally feels well, there's a reduction in inflammatory markers within 2 to 3 days. What about Staph aureus bacteremia associated with MRSA? So first of all, what is MRSA? So we're talking about methicillin-resistant Staph aureus, and this was first described back in the 60s when methicillin was first introduced. It is generally conferred by resistance by the penicillin-binding protein 2A, and this is encoded by the MSSA gene. And this confers resistance to methicillin as well as other anti-staphylococcal penicillins such as clox and fluclox and oxacillin. And this MSSA gene is located on this mobile genetic element called the staphylococcal chromosomal cassette, which can mediate horizontal transfer and resistance, which is important for infection control purposes. What are the therapeutic options for MRSA? Well, there's lots of different options for MRSA, particularly when we're looking at different sites of infection. There are far fewer when it comes to bacteremia. But if you look overall, cell wall acting agents such as beta-lactams like ceftaroline and captopril, other glycopeptides, vanco and teicoplanin. The lipoglycopeptides, the newer ones, telavancin, dalbavancin, oritavancin, also useful. Fluoroquinolones may work. Drugs that inhibit folate synthesis, such as Bactrim, as well as tetracyclines, as well as linezolid. So there are many different drug options. Most of them could be options for different forms of infection, say MRSA, skin and soft tissue infection. You may consider drugs or bone and joint infection as step-down therapy. Many of these you would consider, but when we're looking at first-line choices for MRSA, bacteremia, really the most evidence is for vancomycin. Generally, we give it in a dose of 15 to 30 milligrams 12 hourly. Remember, with a loading dose, it's a kind of 20 to 30 milligram loading dose. There may be nephrotoxicity at higher trough concentrations, and you need to monitor it either via area under the curve, which is the newer and more accurate way to monitor, and is associated with less toxicity, or using trough dosing, which we generally use because it's a little bit easier for us to do and less organized clinical settings. Daptomycin is the other option that is well researched and has got a decent amount of evidence and is shown to be non-inferior to vancomycin for MRSA. One thing to remember is not to use it for pneumonia associated Staph aureus bacteremia because it is inhibited by lung surfactant. You may develop some treatment failure on therapy. This may develop due to NPRF mutations, and there is some cross-resistance with vancomycin intermediate Staph aureus as well. Other options, teicoplanin, which has got a very similar spectrum of action to vancomycin. It's very similar, except it's got a longer half-life, and it's a bit better tolerated with a lower risk of nephrotoxicity. And then linezolid does need some further study. There have been a few smaller studies that have shown equivalence with vancomycin, but generally is not considered a first-line option. And it's generally used when your first-line options are not possible, not available. There also is some resistance among some MRSA isolates, so you need to ensure that it is actually susceptible to linezolid. And obviously we have the issues that we're quite well aware of, is the safety concerns with longer term use of more than 2 weeks at these kind of IV doses that we would be using, which are obviously higher than the doses we typically use for drug-resistant TB. Some drugs not to use, particularly in monotherapy, fluoroquinolones, rifampicin, clindamycin, and doxy are not drugs you're going to use in monotherapy for Staph aureus bacteremia. You may well use these drugs for other forms of Staph aureus associated infections, soft tissue, skin, but a bone, but you're not going to use it for bacteremia. What about new developments? What newer drugs are available? And I mentioned a few of them already. So the 5th generation cephalosporins like ceftaroline, quite widely available now and not ridiculously expensive. Ceftobiprole, I haven't had any access to that. Your lipoglycopeptides like telavancin, dalbavancin, and oritavancin are very promising because they have also got longer duration of action, so you can use them more intermittently, sometimes once a week or even sometimes once a month with some of them, and are very promising. And then some very resistant infections has been, a few studies have shown the use of bacteriophages for MRSA particularly, and so there's a bit of research, or a lot of research going into bacteriophages and the use of endolysins as well. Not yet commonly available, mainly in kind of small research use. Does using more than one agent concurrently result in better outcomes? So this is a summary of some of the combination trials, which generally have showed very little, if no benefit at all. Those that have shown benefit have been quite small studies. So 2 small studies shown benefit for the use of daptomycin plus ceftaroline when used against vancomycin for MRSA bacteremia. So in terms of the evidence, there's a little bit more for this combination, but generally there is a paucity of good clinical trial evidence that would guide this question. And so the question really would be what combinations would work. And what about vanco plus cefazolin or ceftaroline, or dapto plus one of the other beta-lactams, or dapto, vanco plus clindamycin? Some of these questions may be answered by the SNAP trial, which is looking a bit at combination therapy. But at the moment, combination therapy should really be reserved for salvage therapy until we have a bit more evidence. What about oral therapy for Staph aureus bacteremia? So this is a relatively hot topic. We know that generally, as I mentioned, about 14 days of IV antibiotics is recommended. But at what point it might be safe to switch to oral therapy, considering the fact that we know that oral therapy is equivalent in many other infections, is really a matter of debate at the moment. So we know from the POET trial, it showed that partial oral therapy was non-inferior to full IV therapy for left-sided IE. But when applying this to Staph aureus bacteremia, only 22% of them had a Staph aureus associated infective endocarditis, and none of them had MRSA. So the direct applicability to Staph aureus bacteremia is not there, although it is suggestive that there may be more to come in this space. The Sabata trial has been completed, although I haven't really been able to find the final publication, although it was presented at ECMID last year. And it showed that there was non-inferiority of an oral switch after 5 to 7 days of IV therapy compared to a 14-day course. And so this is in a small group of patients with low risk of complications. So these type of patients would be, and this was actually taken from that POET trial, would be patients that have a good reduction in inflammatory parameters. They clinically have responded well. They don't have any deep-seated infection or inadequate source control. And they have a DEFA vest, so they've had an absence of a fever for at least 48 hours and the negative follow-up blood cultures. So the problem is also how common are these patients? But for patients do fulfill these criteria, it may have significant benefit getting them out of hospital early, and sparing them some of the complications of hospital admission and costs associated with that as well. But to look at how common it is, this was a couple of studies that were done looking at the duration of therapy for uncomplicated Staph aureus bacteremia. And for the study by Talpin that I mentioned earlier, they screened about 600 patients in order to find 64 that were eligible. So only 10% of those that they screened were actually eligible. This study, which is a much bigger study, only found 2% of the patients were eligible. But that doesn't mean that in those patients that we couldn't consider this as treatment. It just means that you've got to look carefully and make sure that they would satisfy all the criteria. But this is a developing area. Finally, how can we summarize this all? So I'm using this lime and soda mnemonic. This is developed by Jeremy Null and Lauren Richards, and adapted it a little bit by myself. So maybe this might help you to remember some things. So generally, lime and soda L stands for lines. So remember that lines are common source for Staph aureus bacteremia. We should remove them when we can, or change them if we can't remove them. Be sure to make sure that the patients are receiving the correct dose of therapy. We often find cloxacillin is given at the oral flu-clox dose, at least when we go review patients. Make sure that vancomycin is given appropriately and monitored appropriately, and cefazolin given an appropriate dose as well. The M, look for metastatic infection. We go through that a little bit more in some of the other parts of the mnemonic. An echo, as I mentioned, this is associated with improved outcome, reduced mortality. The S, skin and soft tissue. Consider that as a very common source along with lines. So always look and check the skin, check the soft tissue. I remember having a patient who we didn't know, had a patient in the ward for a few days, didn't really know what the source was. Then eventually when someone asked how he's feeling, he had a very painful leg. When you actually examined his leg, you could feel that there was this kind of fluctuance with a bit of aspiration, got pus. And so this had been ignored because it was under the covers. Patient hadn't been examined properly, and was the obvious kind of source of this patient's bacteremia. Don't forget to look for osteomyelitis, particularly vertebral osteomyelitis. Septic arthritis might be a bit more obvious, but look for back pain and investigate appropriately. Monitor for effervescence. You want to see that temperature is improving, or the inflammatory markers are coming down to indicate that you are winning. And then remember to do another culture. After 48 to 72 hours, you'll also find this as a common error. Patients, or many doctors, will start the treatment, and then a week later, they haven't repeated the culture. And when we're talking about duration of therapy, we're generally talking about duration of therapy after a negative blood culture. So where you have someone who had a blood culture done on admission, a week later, you're now deciding how long you want to treat for, and you haven't repeated the blood culture to document clearance. You're not really sure how long you need to treat for. And then also don't forget monitoring. Patients who are on anti-staph drugs, things like cefazolin, can cause interstitial nephritis. Clox can cause hematological dyscrasias, rash, and hypersensitivity. So do consider that, as well as the renal dysfunction. So monitor an FBC and a creatinine, possibly weekly if they're on it for a long period of time. We know more about monitoring vancomycin for the nephrotoxicity. Daptomycin, remember, although it shouldn't be used in a pneumonia, an infective staph pneumonia, it can also cause an eosinophilic pneumonia. And linezolid, we know quite well from our use in TB that the myelosuppression is quite significant. So at that point, I'll stop and take any comments or questions.
Cool. Thanks so much, Lyle. I've just realized as we finished that I didn't put up the CPD links. I'll put that up in a second as we go. But I guess just to kick it off, so please do put questions in the comments, but to kick it off, I mean, some of the some of the other issues with the cloxacillin dosing is the debate about the right dose, and probably certainly for bad Staph aureus infections like bacteremia should ideally be 2 grams 4 hourly, which is 6 times a day, which is very hard to give. Often it's sort of rationalized a different way of being 3 grams 6 hourly, so 3 grams 4 times a day. But that's not quite the same. In fact, it's only marginally better than 2 grams 6 hourly because of the different pharmacokinetics. So I think, to my mind as well, it's one of another advantages of cefazolin is really that we know we can give the right dose relatively easily in a TDS form, whereas clox is a bit tricky to give in our setting. And I think, in an ICU setting or somewhere where you really can give a medicine 6 times a day, that's fine. But if not, it's tricky. And similarly, I think, with the vancomycin issues, you very nicely showed how, it's clearly not a first-line drug. But I often wonder about vanc versus daptomycin for some of our infections, given the challenges of actually getting good drug levels, and and monitoring the vancomycin and dosing it correctly in our setting is a lot harder than it is in some first world settings where there's sort of pharmacologists to help out here. And I don't have a good option for that. We use vancomycin as our frontline MRSA drug, but I do wonder if the study was done here whether we would see a big advantage to daptomycin, which you didn't see in the first world setting, purely because it's just a lot easier to give. But obviously, it's totally speculative.
Definitely, we had an issue recently with getting vancomycin levels. It was taking us 3 days to get the levels, at which point it's really unhelpful. And so some patients we even switched to other therapy just because we couldn't really monitor them as well as we'd like to.
Yeah, absolutely. It gets very tricky. There's a question about the dosing of daptomycin in the chat.
I can't see.
Sorry. The question is just what is the dose of daptomycin is the question.
Sure, I think generally I'd have to look it up, really. Can't remember it off the top of my head. Because we don't.
Yeah, it's very rare. So the usual kind of package insert is 4 milligrams per kilogram, but it goes up for severe infection. So yeah, for Staph aureus bacteremia, usually 6 is the recommendation. But if the MIC is a bit dodgy, it's gone higher, and then endocarditis even higher still. So it's a little bit vague as to the exact dose. There's a lot of debate about how to dose it. I think on average, my understanding is, unless it's a sort of mild skin and soft tissue infection, you're really probably heading up to about 10 to 12 for the endocarditis, if I'm not mistaken. But it's a tough one to dose. It doesn't seem to be a lot of dose-dependent side effects, which is good. So it also sort of favors slightly higher dosing if there's doubt. But there's a lot of what's on the package insert different to how it's used in practice, I think.
Yeah.
Let me just see. Sorry, I'm just going to put the link in the chat while we talk for a bit. Sorry, not on top of that. For CPD points. All right, so you can click there, the audience in the meantime. Yeah, it's astonishing, isn't it? Also that we've just not got this far in ID without getting clear answers on these studies, on these issues. But it's good and really gratifying that hopefully we'll get them soon via a number of trials which are going on, as you mentioned. Apparently today is World MRSA Day, which is
that's
very fortuitous. And then, this is a good question about the management of Staph aureus bacteremia with CNS involvement in South Africa. And then the question is it safe to assume that cloxacillin would have similar efficacy to oxacillin or nafcillin, which are the agents of choice in the US?
Yeah, so for us, cloxacillin is generally the drug of choice for CNS Staph aureus. There is an increasing research or thought that maybe that cefazolin may actually be better than what we thought, and that may be okay. But for now, in terms of clox would be the drug of choice.
Colleen Bamford's writing that. Oh, sorry, go ahead.
Yeah, so renally, she mentioned renally adjusted dosing for clox is recommended by the French. Sure, so maybe it's not globally recommended. Many people don't suggest renally adjusting clox at all, but sure.
Cool. Halim is mentioning 6 milligrams per kilogram per day. That's presumably for the daptomycin.
For daptomycin, yeah.
And then, I mean, you did mention it, but the question about, cloxacillin dosing versus oxacillin dosing and things like that, they're identical as far as I know. So that's helpful. For whatever the dose of oxacillin is in a guideline from the USA, you could use the same dose as cloxacillin. So that's handy and not intuitive either, because it doesn't have to go that way.